Welcome to the inaugural Health and Wellbeing session, which is part of our professional development. I'll just get my slides up, please. One thing before we start, because we've got a small group and we're doing interactive sessions, I'd just like if a few of you can come down and move down towards the front of the the hall, please, because we will do an interactive session. For ophthalmologists in the audience, John, my co-chair, has organised CPD points if we do the interactive poll for all of you that are here. All right, I'll get my slides, please. So I'll just do a brief introduction about the Health and Wellbeing Group, where we've started and where we're going. Yep, can we get it going? Thank you. All right, so ophthalmology, ophthalmologists, why do we exist? The uniqueness of ophthalmology being non-surgical and surgical, there are many reasons that all of us do what we do. However, there is a cost. The cost can be a burden not only financially, but more importantly to our health and well-being. So the Health and Wellbeing Group was initiated in March 2020 when COVID hit. We started as a group, the original group. John McCoombes and myself were chairs. Arthur Karagiannis, Di Simmons, who were past ASO president and vice presidents of the college, joined our group. And we had an overwhelming response from trainees. Seb Brown was a senior trainee in Sydney and Mia Zhang was a first-year trainee. We were promoted by the college to a formal committee, noting that health and wellbeing is important for our profession. And when we sent an expression of interest out, we had an overwhelming response from trainees that wanted to be involved. So what we did, we set up a subgroup, a sub-trainee group, so that they could deal with issues within their training that they've had. What do? We send out monthly e-newsletters, so monthly emails. All of us go through the emails. We also have a feature in each edition of Eye to Eye, and anything that we have posted over the last 2 years is actually on our website. There are two portions to our website. One is public and one is just for fellows or associates. So a lot of our health and wellbeing is actually open to the public. John has been instrumental in organising the campaign for having a regular GP and also keeping yourself well brochure. And as we will talk about later in this session, we are developing and launching a mentor program for ophthalmologists mentoring each other. I do believe that health and wellbeing needs to commence during your training. So we have a session during the eye camp. So all trainees have a specific training eye camp that's over 5 days prior to their training started. We have a 30 to 45 minute session on health and wellbeing and how to cope with stresses during training. It is senior trainee led to help junior trainees before they've started their training. And we've outsourced to Patsy Tremaine, giving webinars for basic trainees. As we will see later in this session, we've had support and correspondence with other colleges. And one thing that we had to do was give feedback on a medical board registration standard, where they actually wanted us to have health checks for what they termed lay career doctors. From a health and wellbeing perspective, we did not think that this was a great idea. So for those of you, if you ever need any help, where do you go? The college has had for many years an employee assistance program. It is a program that is entirely confidential. It is outsourced, but it is paid by the college. And it actually provides assistance with anything. If you're a leader, a practice manager, ophthalmologist, or anyone who needs assistance with dealing with relationships within your workforce, finance issues, interview practice, you can actually ring a confidential number. you'll get triaged over the phone as to which department will call you, and then you'll get a phone call from whoever they think is appropriate. There's also a subsidiary of the AMA called Doctors for Doctors. So just showing you from just a few snips from all the Eye to Eyes that we've done. We have a section in every Eye to Eye magazine that is health and wellbeing. There are a lot of feature stories. We show ophthalmologists that have different avenues in life, from sailing, bird watching, Arthur and his yoga, and we've outsourced a few issues that discuss how to cope with certain stresses that we have in our life. And Justin Mora, who is no longer Censor-in-Chief, shared his journey with dealing with some family issues. So as ophthalmologists, we're good at looking after our patients. We're getting better at looking after ourselves, but how do you cope when there's some family issue chucked into the mix? So Justin's given he's shared his story. And obviously there's always a silver lining. Daniel Ting, who's Associate Professor in Singapore, came and talked at the New South Wales branch meeting recently, and I quote him, "Never let a good crisis go to waste." There's always a silver lining, and we have seen silver linings with COVID of looking at alternative ways to live in addition to ophthalmology. And one thing that we will talk about later in the program is the RANZCP mentor program. If you would like to be someone who provides mentoring to another ophthalmologist or would like to be paired up with someone who needs mentoring, we're always looking for people. All right, thank you. So we'll move on to the session. So I'd like to invite Arthur Karagianis to come and introduce the next speaker.
So I'd like to introduce Andrew Czuchwicki, who is my anaesthetist for quite a number of years. He's the senior staff specialist at one of our local public hospitals, and essentially works privately with me as his only private part of his practice stop. His interest really in mindfulness started from a personal period of depression, and he did find both yoga and mindful meditation quite beneficial in moving forward. He's done extensive training in mindfulness-based stress reduction at the University of Massachusetts. So he's travelled quite extensively overseas for this type of practice. He's also done an MPEAK coaching course at the University of San Diego, and he's done over 500 hours of yoga accreditation. So he put me on this path some 8 years ago now, and I came from a background of being completely antithetical to this type of stuff, and here I am doing yoga poses now. So there is benefit in this type of thinking, and I look forward to hearing from Andrew. Thank you.
Hey, hello. I can't see you, so I'm assuming you can see me. Is that all right?
Yes.
Yeah, fantastic. Thanks. Welcome everybody. Thank you for taking the time out of the conference schedule to share your precious time with me and your fellow ophthalmologists who are interested in this sort of approach. And maybe you're someone who's dabbled in the practice or practices, or someone who's just curious and is just wanting to know why would you bother? So I'm just going to start with a little bit of a screen share, and hopefully you can see that. So essentially, I'm going to talk a little bit about what is mindfulness. So mindfulness is actually a state of awareness that arises from paying attention on purpose in the present moment, non-judgmentally. Now, that's the definition from John Kabat-Zinn, who is basically credited with being the father of Western mindfulness. And you might think, well, that's not too different from what I do when I work. I pay attention on purpose, but the difference is that it's an attention that takes in the entirety of the present moment rather than a focus on what you're doing. And there's often judgment involved in paying its focused attention into the quality of that attention, and also a focus is on a process that you're unfolding. And often there is a rigidity about that awareness because you're sort of naturally working through a process that you've practiced many times, and it's important that there is that consistency of your practice. So there is a difference in the nature of the way you're paying attention between the two. So without sort of going too much further down the presentation, I thought I'd just give you an experience of what it's like to pay attention in this way, because essentially mindfulness is like learning how to do cataract surgery. It's experiential. You can't just read a book about how to do cataract surgery. You can't just watch a video about it. You really have to do it, and then you have to get feedback on what you're doing from an experienced teacher, an experienced instructor, and then you make adjustments and adaptations in your technique based on that feedback. The challenge with mindfulness is that the experience is going on literally in your consciousness, in your awareness, inside your head. So the importance of having someone who can facilitate your sort of development is really important, because it's like then trying to learn to do what you do in the theatres, but without having any feedback. It's sort of like just going ahead as best you can. So what I'd just like you to do, just to experience a little bit of this practice, is just wherever you are, just sit yourself tall in your seat, place your feet firmly on the ground, and just rest the hands on your knees or your thighs or in your lap, and just close your eyes. When you close your eyes, you might just be aware of many, many things. Everyone will have different things that they're aware of. But what I'd like you to do is bring that attention just to your breathing. And just experience your breathing wherever you feel it most connected to. Perhaps it's in your nose. Perhaps it's at the back of your throat. Or perhaps the way your chest is moving. Or perhaps you have to go all the way down to your abdomen and just feel how that moves as you breathe in and as you breathe out. Now, for a lot of you, just this simple redirection of your awareness to the breath may have decreased some of the distraction that you've been experiencing before you closed your eyes and did this, or even as you closed your eyes. So in the first part, this sort of practice is calming to the senses. And then from sort of a practice of just becoming aware of the breath, become of the fact that you can shift your awareness. So as you next breathe out, I just invite you to take that awareness, just to send it to the soles of your feet. And just be aware of whatever you're experiencing through the soles of your feet. Perhaps there's nothing, that's fine. You're aware of experiencing nothing in the soles of your feet. Or perhaps there's other things you're experiencing, other sensations. No judgment, they're just sensations. No judgment as to how well you're experiencing them or whether it's the right one or the wrong one. It's just whatever's there. Now, as you next breathe in, draw your awareness up and just take in both legs. Just experiencing the sensations from both legs. Maybe there's a particular area of your legs that's giving you more information, more sensation. Maybe it's the very top of your legs. hips, perhaps it's your knees. Perhaps there's nothing that's particular. You just get sensations from here and there. Then come back into your torso and just once again, feel the breath. This time feel the breath in your body. Just the whole experience of what it's like to breathe. And while you sit here breathing, just notice the experience of sound. And usually when we experience sound, the first thing that happens is we like to name the sound, identify the sound. Just let go of that. Just allow yourself to hear sound. And you'll notice how the sounds will appear in the sense of hearing. And then after a time, they'll move away, subside. You don't have to do anything. You're just aware. And there's sounds that are far away. And there's sounds that are close. Perhaps you perceive the beating of your heart, sound of your breath, the rustling of your clothes. The sounds coming and going. Next time you breathe out, just release your attention from sound. Come back to the breath. And this way, train yourself to be able to move your attention, move your focus in this way. And as you sit with the breath, you may notice there are thoughts coming and going. Just the way sounds did. Here comes a thought. It's just a thought. If you don't pay attention to it, if you just notice it come, it'll just go. And again, with thoughts, we sort of think of them as good thoughts or bad thoughts, useful thoughts. And when we apply our awareness, our attention to thoughts in this way, we recognize that thoughts are just thoughts. We don't always have to pay attention to them. We don't always have to do as they tell us or instruct us. We can become someone who responds rather than reacts. And this is just mindful attention to the immediate experience of senses, of embodiment, but we can expand that attention to take in our surroundings. We can apply the same quality just to notice what's present in the moment. There's an expanded awareness or a narrowed awareness. Just as the breath expands and contracts, so can your awareness consciously expand and contract. And in this way, we sort of feel the moment is richer and fuller. We're more in control. We're more able to respond rather than react. Just take a deeper than normal breath in. Just feel that sensation filling your body. And as you breathe out, just open your eyes. And just notice the quality of your presence now, the quality of your state of being. That took, I don't know, maybe 3 minutes. Maybe for some of you, it was coming back home to a practice you're familiar. For others, it may have been the first time you've ever experienced anything like that. So I'd like to just dispel a few myths about mindfulness because there's a lot out there. Now I'm going to tell you what it's not. It's not relaxation, even though it can relax you, because sometimes you're present to how stressed you are. Sometimes you're present to how anxious you are, or angry you are, or sad. So with that, it can produce relaxation, but it's not done to relax you. It's done to pay attention. And maybe in that moment of attention, you decide you need to relax. You need to take that life-affirming breath and let it out slowly and just chill out. And let go of the things that's annoying you or disturbing your focus or disturbing your concentration rather than react. You know? Being at choice rather than reactive. It's not concentration. It is paying attention in a particular way, but it's not that same focus narrowed down. It's more open. It's more fluid. It's more responsive to what comes and goes in the moment. It will improve your ability to concentrate. for longer periods of time, because you train your mind to be calmer and stiller. So the things that disturb you no longer disturb you. It's like the sound that we let it come and we let it go. We have to try to control it or shut it out. We just let it be there, and we change our awareness to a different place of attention. It's not traditional meditation. I practice traditional meditation, and mindfulness is probably the basis. So it's the set point that you start from, but it's not traditional meditation, and it's not religious. Mindfulness, as it's used in the West, was deliberately designed by John Kabat-Zinn at the University of Massachusetts to be secular, to remove all the elements that have spiritual connotations. And as such, mindfulness is used in, top corporations like Google. It's used in high-end sporting teams like NBA basketballers and National Football League players. Olympic teams use mindfulness, and so does the military. The military uses mindfulness to train their high-end special forces soldiers. There's nothing spiritual or religious about what they do. Now, if at any time you've got any questions for me, you can put them in the chat. I don't know if I've got a smaller little box here with the screen share, but maybe they'll come up. So if there's any questions, you can put them in the chat. Otherwise, it's me talking and you listening. So as long as you're breathing, there is more right with you than wrong with you, no matter what challenges you are facing. John Kabat-Zinn. Challenges and difficulties are workable with mindfulness. You become the ability to create a space in which you can make choices, see the bigger picture. So mindfulness is a fundamental to this approach. It's the present moment. It's the only time you ever have for perceiving, learning, growing, and transforming. And you see mindfulness is added to a lot of different psychological modalities. Why? Because it's great to have all those modalities and tools, but if you're not aware of when you need to use them, they're useless. So you've got like mindfulness-based stress reduction, mindfulness-based cognitive therapy, mindfulness-based compassion, mindfulness-based insert sort of thing here, okay? But the underlying basis is this mindful state of awareness. So what are the benefits? Well, there's less reactivity. You don't get as annoyed. So when you're operating and there's something that happens, and Arthur can attest to this, the less reactive you are, the easier the day goes, the less tense you are, the less stress you have, the more cases you can do, the more productive you can be, but not in a way that's actually draining you and wearing you out. So, we can, when we're younger, keener, we can sustain all sorts of levels of activity for probably many years and decades. And that's what I found out, that the level of activity that I was sustaining was maintainable up until I couldn't. But I wasn't aware of that. Yeah. There's more opportunity to choose. Yeah. You can choose the words that you say. You can choose the actions that you take. You can choose the attitude that you have. And you can be consciously making those choices rather than running on reactivity or patterns and habits, which may serve you well, but not in every moment, not in every time. The things that work well in one situation and circumstance may well be quite the opposite of what's required, when you move, say, from the work environment to the home environment or to the social environment. There is improved coping mentally, emotionally, and physically. Why? Because you're more in tune with the messages and the signals that you're getting from your body. In practice, this is called interoceptive perception. So you've got proprioceptive perception, which you guys know all about, the fine motor work that you do. You know exactly what's happening with those little tiny movements and adjustments that you make, because you practice and you pay attention. In a similar way, by sort of doing these sorts of internal scanning practices, you really get perceptive of what's happening in your body before it gets to a level where it has to demand your attention when you're not paying attention. So again, you can sort of notice those things and take action as a prevention rather than actually waiting till things break down and then you're searching for cures. It's improved self-care. We talk about self-care. This whole thing is about self-care, but part of that is knowing when and knowing how and knowing what works. We can all make choices around self-care, which may be good in the short term, but in the long term, we have to pay a price for those. is improve relatedness to yourself. You learn to be a lot less harder on yourself. You learn that there is things that you can control, things that within your capacity to choose, and then there's those things that happen that are completely out of your control. And when you recognize that distinction, there's less being hard on yourself. And as medical practitioners, we can be our own worst enemies in that when things don't go well. And I know that from the long career I've had in medicine, that things, no matter how diligent you are, no matter how well you've practiced, that things can still go badly. And often those are the situations that can haunt us. And if we have that capacity just to be aware, it sort of improves our capacity to sort of move forward, be kinder. And essentially, it's not therapy, but it can be therapeutic. I mean, I discovered that when I had my bout of depression. I was receiving, professional help and support with medication, and that was very useful. I would not recommend to people not to do that if that's what's recommended and required. But really, it was the mindfulness practices, the self-awareness practices that actually helped me recover enough to actually come off the medication and not need the treatment and maintain that. And if you think, oh, well, that's just a nice story, it's only a case report, it's biased. However, there was a recent study done in the UK which compared mindfulness-based interventions with prophylactic antidepressants in mild to moderate depression in terms of effects on relapse. And this is what they showed. There was no difference in relapse prevention. And so you think, oh, well, there you go, it doesn't work. Hang on. This is a multi-billion-dollar pharmaceutical industry that's invested billions and billions and costs billions of dollars to produce these medications. And they work just as well as if you sit and watch your breath for 5 minutes a day. So the thing that I always say, having personal experience with those medications and those therapeutics, they have side effects. They're not pleasant. And one of the challenges is often for the prescribing physicians is to balance out the side effects with the benefits. It's no good having an increased mood when you're suffering from all these other side effects. However, mindfulness has side benefits. It just improves, dare I say, everything. It can work across all aspects of your life, not just in that particular condition that you're addressing. So who can benefit from mindfulness? Well, your medical practice. You're more related, you get on better with your patients, they like you, they talk to their friends and they say, go see Dr. So-and-so, they're really great and relaxed. They don't seem to be stressed or angry or get short or upset with me. Your relationship with your staff, staff interrelations is very important. A happy sort of staff is a happy practice, happy patients. You want that sort of thing. So your practice of medicine improves. Your mindfulness, I teach a mindfulness performance. That course is designed to use mindfulness to help elite athletes get better. So these were people who were at the top of their game. They were all Olympic athletes. They'd made the Olympic team. And they decided, in addition to their specialized training, which is exactly what you guys are, you had specialized training, you're at the top of your game, you had to be good to get into the training and you got better. You're at the top of your game. These are the same as these elite athletes. They live, eat and breathe training and practice and performing. And they basically were using mindfulness to actually help them improve their capacity to perform. Your patients can benefit from mindfulness, from you directly, but also mindfulness has been shown to help patients cope with chronic illness. And by cope, you'll have patients that you see and you have to manage their illnesses are chronic, and it impacts them. It does create suffering. The original intention behind MBSR from John Kabat-Zinn was to help patients that medical help had come to the end point of what it could do for them. So the MBSR was designed to make them feel better and have better lives, even though their conditions were no longer improvable by modern medicine. And again, if you're practicing, you're the best advocate. You know exactly what it does and what it means. So just referring it to them if you're not a practitioner, it's one of those things, do as I do, do as I say, not as I do. And you personally, and at home, in your social life, whatever hobby or sport you engage in, mindfulness will make it better. You will be better at it. Golfers use mindfulness, cyclists use mindfulness, climbers use mindfulness. Yes, they're sometimes in a meditative state when they're actually in their chosen sport. However, that sport will not improve their medical practice or their interpersonal relationships, but mindfulness will. So, how do you do it? There's formal practices. It's like training, all right? You do that to develop any skill. It's a series of specific exercises to develop your own mindfulness, okay? And there could be different approaches to develop the conditions for mindful awareness. And then there's informal practice. This is applying those skills in day-to-day life. And this is probably more important than the formal practice, because the formal practice is like training, and life is the game that you're training for. Mindfulness becomes your way of being, right? So what are the practices? There's mindful eating. You can eat mindfully, okay? There's breathing. You can just breathe with mindful attention. There's mindful scanning, like we did in the body. And there's reflection, mindful reflection. From that place of calm, that place of ease, of openness, of curiosity, of non-judgment, you can reflect on things, your thoughts, your memories, your actions, your choices in the past, how you can look at that moving forward. And the common thing in medical practice is people say, but I don't have time, I'm busy. And I know you guys are all busy. Arthur's super busy. I can't believe how busy he is. But you eat at least once a day. You should. If you're not, well, there's a problem there. You breathe all the time. And you can scan the entire body in 3 cycles of breath. Legs, torso, arms, and head. Okay? And you can always just stop. So what stop? Just a quick little thing, a tool to take away from here. Stop. Just stop where you are. Stop what you're doing. Be still. Take a breath or two, the way that we did, just with that, attention, that focus. And just open yourself and observe. Observe yourself, observe others, observe the situation, non-judgmentally, with that openness, that curiosity, that wanting to know what's going on. And then pause and reflect. What are my choices? What would I like to do? What would I like to make happen in this moment? And if it doesn't work, do it again. Until you actually find yourself in a place where you can make a conscious choice. So what can you do at home to start? We can eat 1 meal a day mindfully. It's small doses many times. Deliberately create moments of paying attention to breathing, emotions, and thoughts. Set an alarm. Do it 3 times a day. Do it before you have a break. Do it before you get out of your car when you get home, just to check in with how you are, just noticing without judgment what's present, and begin to access those innate resources to cope and meet life in ways that are less conditioned and more appropriate to what's occurring. So thank you. Reflecting on that, any questions, I'm happy to answer them. That is my favourite view. That is the pond at Chapin Mill, which is a Zen centre up in upstate New York, where I go to learn to facilitate mindful practice. So we'll stop there. And any questions?
Great. Thank you very much, Andrew. Do we have any questions? Otherwise, we will move on. No, we're done. Thank you very much for your time.
Thank you very much.
Exceptional.
Thank you.
Thank you.
Thank you.
Either or. Okay, so the next session we have is about posturing, and one thing that we definitely need to do is posture well in our clinic and when we're operating. So Anne Malatt, who is our co-chair at the moment, will introduce our next speaker. Thank you.
Hello, everyone. I've asked Kate Greenaway to come and present to us. She's a very well-trained and experienced physiotherapist who's been a physio for 35 years now. And initially, her training was very conventional, and she spent a lot of time travelling overseas, supporting sporting teams and things like that, and doing more training overseas. But for the last 20 years or so, she's been based in the Northern Rivers of New South Wales and has co-developed a new therapy called connective tissue therapy, which is a very gentle treatment. And she's been my practitioner for over 20 years, has totally revolutionised my body and my life. And from having chronic neck and upper back and lower back problems, I don't have those things anymore. And as a result, have much more vitality and energy and enjoyment of life. So we thought we would share some of this with you. It will be a very simple and experiential session, and we should have a bit of fun. So with no further ado, well, I'll introduce Kate.
Thank you. Can you hear me, everyone?
Yes.
Yeah? Yeah. Hi there. Thank you for this opportunity. It was wonderful when Anne asked if I would come and present about the things that, some of the things she's mentioned and what we've worked on a lot over the years to help her with her work. I also actually see her as a patient. So I have, physiotherapists are all about movement, and we observe movement to the nth degree. And sometimes it's actually a bit painful when you watch people and how they move. But for your fine work and the pressure that you work under and the machinery that you also have to work with, your skills are very varied, but they're very precise, and they ask your body to be in postures that are sometimes very compromising. So if we could just have the slides up, please, for the connective tissue. Oh, they're there. So
Press the green button to...
press the green button.
No, on the click.
Oh, yeah, right. So that should load.
Yep.
Should load up here.
Yep, can we get them loaded, please? And press the green.
Here we go. Fabulous.
There we go.
There we go, the next. But before I get on to the specifics of the connective tissue, because it's an area of the body that not many of us know real specifics about unless we have a particular interest in it, I'd just like to get a bit of feedback from you. How many of you have had intermittent or even chronic pain in your neck or headaches associated with your working activities? Okay, so quite a few there. Yeah, quite a few.
About 90% of the room.
You're right. How many have had chronic low back pain? Yep, okay, a few. And mid back pain, so between your shoulder blades or around your waist? Yeah, okay, all right. So there's across the board there. So often when ergonomics are educated either by physios or occupational therapists in the past, they've been fairly, what I would say is dictatorial, but they're not coming from a fluidity of understanding the adaptability of connective tissue and applying that from perhaps their own bodies. I work with the posture of my own body all the time, and I'm always sharing with my clients. Because as Andrew said, you've really got to walk your walk. Otherwise, I don't exactly look like somebody getting to the end of my degree, end of my career. I love what I do. I'm passionate about what I do. I'm very active. I'm very vital. And I wasn't like this 30 years ago. I had chronic neck pain. I was getting on the edge of depression because I couldn't do what I love to do because of the pain. But all of that is gone. So everything that I shared with Anne, I actually worked on my own body. So connective tissue, remember those old days of anatomy and physiology, and we would see the white stuff that would cover the muscles perhaps, or around the muscles or around the organs, and we'd push it aside and we'd check out what the real structure was. Well, connective tissue is actually all through the body, so it's not, it doesn't begin or end. So it's actually in the organs, it's around the nerves, it's part of the nerves, it's part of the brain. It's not just muscles and ligaments and the fascial sheets that cover the muscles. Yeah, so you could actually say, because there's connective tissue fibers in the cells, our very cells, so you could say we are actually all connective tissue. The actual type of tissue itself specializes to the different organs and muscles and structures, but it has a commonality in that it is very sensitive tissue, and it also has a lot of pain fibers. So when you've got that tension in your body and you just can't seem to get to it, I'll not press on my microphone, and you get a massage and you get temporary relief, but it seems to come back in a very short space of time. That tension is held in your connective tissue. So if you stretch and try and overstretch something or stretch something rapidly, that's an insult to the connective tissue. It reads it as an insult, so it actually starts tightening up. So there is a real science to releasing your connective tissue and to have it released in the long term. Yeah? So it has what is called a creep factor. Okay, I always laugh a bit at that term. That's in the physio land. But what that means is it has memory. So if you go to use your slit lamp, I had some education from Anne, the slit lamp thing, you know, where you put it and people line up and their chin and you're adjusting it. Well, if you're in the posture, like I saw a fellow do a demonstration today, actually, in the exhibition hall, and his posture, can I get you to pop up? I'm going to remold Anne's body, yeah? So this is a bit more of the fun, practical stuff. So if you put that side on, yeah. So can everybody see Anne from where they are, yeah? So in this posture, that's what exactly, oh, there you go, assume posture A, that's exactly what he was doing. And he was doing this, right? And he was adjusting this, and it was some sort of new version of what you use all the time. And it really hurt, so it's not quite so bad. He was like about there and about there, right? But the interesting thing was that after he did what he ever did, he sat back, but he was still like, his arms were down, but he was still like that, right? So that's the connective tissue saying, this is my normal, but her neck is completely collapsed in that position. All the small structures, your vertebra, your joints, the discs are all under lots of pressure. So your bigger muscles, your upper trapezius muscles and your levator scap muscles are working overtime to try and pull you back up to a more long posture, open chest, long posture, but it comes also from your sacrum. So a lot of people focus on the upper body with the posture, but your sacrum's your base, your sacrum's your base in your pelvis. That's where the spine rises from. So all the connective tissue on the inside and outside of the sacrum have a role to play as to whether your spine can be long. So if Anne's spine is long, now we'll go back to the slump and here with the chin forward. So say she adopts that. Look at the range of movement she has when she turns her head. She gets jammed there, and I can feel that that would be quite nasty for her. Yeah? So then she comes back to neutral. She finds her long posture again from her sacrum all the way up, so her spine is light. Yeah, she could hold that for quite some time, and we've worked on this for years. She used to crack her neck. That's all right, I said it. She used to crack her neck regularly because of the underlying tension that she just didn't know how to get to. And I was saying, please don't do that, because you're taking a joint to its end range and you're snapping it. And that might feel good for temporary, but it's horrible for the passive structures, your ligaments, you're overstretching them. You'll end up having instabilities in your neck rather than inflexibility. It's much easier to correct inflexibility, not instability. Does that make sense? So what we did was we kept working on the posture as well as releasing all the connective tissue. And then we did a couple of very simple movements and strengthening of her core of her upper back as well as the lower back. Because you've got core muscles in every area of your body. They don't talk about that. They just really mostly focus on your lower back. But you've got your rhomboid muscles between your shoulder blades, which are your base of support for your wings and your neck and your skull. So we did a bit of that work as well. But look what happens to her neck movement when she's long. See? She's swinging like a rusty gate. She can just swing around and look at you all. Yeah? Okay. So the beautiful thing is that the connective tissue remolds itself every 3.5 to 4 months. So it doesn't matter how much injury you've had in the past or tissue tension or chronic pain. I've seen so many people change with time, but because there's that memory factor in the connective tissue, it will want to go back to what's familiar unless you keep re-educating it, and that can take 10 seconds, 15 seconds of realigning your posture back to its true posture, or what I call your open, elongated posture. But what you need to understand too, as not only as, refreshing what connective tissue is, where it is, how its qualities, how do we work with it, how do we nourish it and support it to hold us in these postures that are not so cumbersome, so you're not exhausted by the end of the day and you're not enjoying your work and you don't have the vitality and energy for other things in your life. Connective tissue is super important for our vitality as well. And these are probably some of the physiology you mightn't be aware of. It actually is such a great support for our immune system. It transports white blood cells around the body. It transports biochemicals. It transports hormones. So, and as if you remember, it's all through the organs. So if you have fluid, flexible connective tissue, then you have a vital body, which means you're going to enjoy your work much more. You're not going to take on little extra things during the day as monumental stresses because you're going to be more vital in the body. If you're more vital in your body, you're going to enjoy everything you do, including your patients and your work. But the thing is, Anne and I both wanted this to be super practical, so you walk away going, oh yeah, well that's all very well to hear a bit about the connective tissue, but what does that mean for my body and my posture and my work and the rest of the activity that I put this body through? Okay, so one overriding thing that I learned a lot about my body in terms of how to nourish the connective tissue is moving smoothly. So it doesn't mean like you're going to be a very studied mover of slow and focused, but you're smooth. You walk smoothly, you move smoothly, you're allowing your body to be more free and fluid. That's on a general theme, but for you particularly to take away with what is your posture. When we all talk about the ergonomics, we talk about the ergonomics of how to use your machinery or your chair or your stand-up desk. But that's not going to help a lot unless you have your true posture or your elongated posture first, So why don't we experiment and you make your bodies your own experiment and find your own posture for where your spine feels the lightest. The easiest to do is in standing. So if you all now stand up, you've been sitting for a while anyway, so it's always great to change the posture for your spine. So remember your sacrum is the triangular fused bone in the middle of your pelvis, So I do watch people walk a lot, not as a criticism or a judgment, but just as an observing. And sometimes, especially in Woolies and Coles, I kind of have to look away sometimes. And it's not an age-related thing, believe me. Like I watch people in their 20s and 30s with really jammed up pelvises, and their hips aren't moving freely. Their spine doesn't have a chance. So I want you to just stand with your feet comfortably underneath so hip distance apart, and your arms are just comfortably by your side. Your knees are slightly soft, because if we jam our knees straight back, full extension, it tightens up your lumbar spine. It increases the pressure through your vertebra and your discs, And this might be nothing for a minute. You do it a lot during your days. As you get older, you feel it. And so you get the wear and tear, early wear and tear. So just slightly soft at the knees. Okay, so can I demonstrate here again? So if we overemphasize postures that are out of whack via the sacrum and up the spine, So what happens to Anne if she actually sits back and bends your knees slightly and tuck your bottom under? So just do that so it's like you're half sitting And just feel, what does that do to your lower back? If you were to hold that for a while, that would actually be a strain. You get that? Okay, now do the opposite. Stand up, have your knees straight, and stick your bottom out. Yeah? And if you were to walk, do you want to walk like this? Just go on. You start walking like a duck, right? So there's not a lot of fluidity there. We haven't done this before. This is completely impromptu. Okay, so now if Anne just stands somewhere with her sacrum in neutral, in between those postures, yeah? You'll know if it's true for you because your spine will feel long, your shoulders are naturally over your hips, you're able to look straight ahead, but your chin's not sticking out, yeah? Your chin just sits comfortably under the nose, yeah? Now, if you have that posture now for yourselves, just for whatever it is where your spine is at the moment, that is your, if you can feel you could stand like that for a while, yeah, that is your ideal posture in standing at the moment. Now, it may change like in 4 months, 5 months, if you keep just every so often during the day recorrecting, yeah? Because you're educating your connective tissue to soften around the bits where it's been tight from compressed postures. Now, if you have that as your base and you keep coming back to that, your connective tissue will remold around that, and then it'll feel foreign and not normal for you to then compress and roll your shoulders in and perhaps stick your chin forward. So if you just let your arms roll, let your hips roll, and just walk with that long posture, and compared to before. So see, she's got full hip movement. She actually has. She's got the shoulders, the arms, everything's going. But it's not overkill. It's not like she's on the catwalk. It's just everything is flowing. So that means that all her joints, her mobile joints, they've got the grease and oil change going, yeah? Remember, you've got this, I think it's called, no, that's lung tissue. There's synovial, the synovial fluid between the bone surfaces in joints. Yeah, I was going to say surfactant, but that's in the lungs. Yeah, so that's the joint. You're actually giving yourself connective tissue therapy if you move that way. Okay, so I probably adjust my posture about 30 to 40 times a day. Now, it's not an arduous thing. It's in between clients, or even, because my postures are either sitting, I might have my hand under their pelvis and the other hand on the lower tummy, doing my connective tissue releases. But before I start anything, I make sure I'm long in my spine in sitting so that I can hold that posture for however long and it's not a compression on my spine. So I don't end up the day feeling absolutely knackered, which I used to in my late 20s when I had my chronic neck pain because I was under so much pressure and compressed postures and pushing on people's spines. It was not fun, and there's a lot of burnout in physios and osteopaths and stuff. So now let's find your true posture or your long posture in sitting. So let's everybody sit down.
About the shoulders. You meant to have your shoulders back.
Yeah. So great question, Mish. So if you're long from your sacrum up and your chest is naturally open and not rolled in at the shoulders, I keep doing that. The shoulders sit naturally back. But at the moment, if you're used to the shoulders rolled forward a bit, you'd be tight in your pectorals and the deep ligaments around your shoulder joint, and you'd be a bit lazy in your rhomboids. So gradually that will open up little by little, right? It's taken you a while to get to these compressed postures. It'll take some months to keep coming back. But if you change your posture every so often during the day, you're constantly re-educating your connective tissue to be in that more open posture. So now in sitting, I'm going to bring it inside on. In sitting, just have a bit of an experiment with yourselves again. Just have your feet forward. So be like a teenager. Slump, straight away. You're there straight away. You remember? You're not that old, so it wasn't that long ago. So legs forward and your bottom's away from the chair, yeah? So just feel, what does that do to your lower back? And what does it do to your neck? So it may actually feel a little bit like, oh, that's actually relaxed. But if you held that for long periods of time, you're actually stretching your passive structures of your spine and you're bulging your discs back. And I bet some of you have probably had neck episodes with discs and joint problems, and that puts way too much strain on all of those joints. So just, we know that that's not true. So now let's overdo it and be like the good student. So you're sticking your chest down and your belly's out. So you're overly tight. You're overly tight in all the erector spinae muscles all the way down the spine, and you're compressing the joints in your lumbar spine in particular at the back. So it's a different sort of pressure on your discs, yeah? Okay, so that's not true either. So for yourselves, find a midway position with your sacrum and your spine that where your spine feels long, and you could sit like that for a long period of time. And test with your own neck movement, can you bring your neck all the way around, or mostly all the way around? Just smooth rhythmical movement. Connective tissue loves smooth rhythmical movement. Thanks. So those are two fundamental postures for you. But the other thing that was hugely, and this is one of my favorite, what would you call that schematic diagram of your thoracolumbar fascia? So the fascia is the word given to just sheets of connective tissue. You probably not all know that. But can you see that? Do I have a pointer here? No, probably not. Can you see how the upper back muscles come down, the latissimus dorsi comes down and joins onto that fascia. The erector spinae is underneath it, all the different layers of the back, and also even the sides, which actually are part of your abdominals, and that's part of your core for your lower back, yeah? So if all of that fascia is a bit tight and thickened, it's going to influence how those muscles work. So I have so many people that come to me and say, yeah, I went to somebody else and they said I had to just build on my core. I went to an exercise physiologist and they kept giving me core work, but all I kept doing was getting sorer and sorer and tighter. And that's because the tissue that holds it all together wasn't actually released. So it wasn't then in balance, so the muscles couldn't work in balance. So I would always stop all the core exercises to begin with. We'd release the connective tissue. I'd give them gentle movements to release their connective tissue, rebalance it all, then gradually do one core exercise, then another. But they always did more gentle connective tissue movements. One simple one for the back is lying on your back, knees bent up, hip distance apart, and you're just gently doing knee rolls side to side. Yeah, so that's one of the fundamentals. But you can do it in sitting at work for your upper body. So for maintaining this length in sitting, all you do, so just try that now, is you're going to loosen up all the structures around your shoulders and your wings. So you basically, probably side arm would be better. Thank you. We need a roller chair here. So you establish your long posture in sitting. So just try this and see how it feels. What you're going to do is warm up all around your shoulders and your wings. So you're just going to pull the shoulder blade straight back. Not up, not near the ear, but straight back. And you're engaging the rhomboids between your shoulder blade and your spine. And then you release it. And then you do the other one. So you're aiming to do it in a smooth, rhythmical way. Connective tissue loves smooth, rhythmical, rotational movement. That's what nourishes it. That's what keeps it flexible and fluid. So you go one shoulder and then the other. Yeah? Now, if you've got patients lined up, you could do this just 30 seconds, a minute in between your patients, yeah? And even if they're running a little bit late. I do this all the time. The other thing that actually, thanks, and the other thing that strengthens in between here, and I know this mightn't be as easy for you to do, but if you do take breaks, just doing that one to free the area up first and increase your connection to the area so the muscles are more likely to work in balance. And then I literally do, I know this sounds weird, but it really works. I do wall push-ups. I literally, you do those, don't you? Yeah. You literally pop your hands just below your shoulder height, you're facing the wall, you don't throw your chin forward, but you're using all your core muscles to lower your body weight to the wall and back out. Now, all you need is a minute, 2 minutes, a wall, and yourself. You don't have to go and change your gear and then do a run around the lap, warm up, and then do your exercises. You need something that's really practical and doable and easy and has the greatest response in your body in between all your patients. Because I know you're under the pump a lot, and I've seen how Anne works. So just simple, practical things like that. The other one thing I want to show you, which found the next stretch, yeah, which found Anne found a huge change in her whole condition, and it stopped her cracking her neck and having the chronic pain. That's one of the biggest things, wasn't it? Okay. Well, this is particularly for the levator scap muscle. So the levator scap, remember, joins onto the very top of the shoulder blade. It runs along the side and the back of the neck, right up to the base of the skull, the occiput. Now, that's one of your most classic tight regions because you're always like doing this with all your machinery and testing of the eyes and stuff, yeah? So you're up, but you're rolled forward, right? So the levator scapulae is getting tighter and tighter, but you've also got your upper trapezius muscles that are trying to work to bring you back, yeah? So they're going to get chronically fatigued. Chronic fatigue muscles are tight, and then the connective tissue thickens in terms of its chronically shortened position. So what you need to do when you stretch any form of connective tissue or muscle is do it gently and gradually, yeah? You don't whack your neck to the side and then try and hopefully it'll fix everything. So you need to anchor the shoulder blade first. So just the same movement that you just did, you pull your shoulder blade back. So if you want to try this, let's do the left one first. So you pull your shoulder blade back, you hold that position, you tilt your right ear to the right shoulder, just until you feel a bit of stretch. But then you do a funky little thing where you turn to look at your right armpit, and that gets the twisted fibers of the base of the levator scapulae slowly stretched. Now you hold that, but then you use a little bit of understanding of the connective tissue. You use your breath. So as you breathe out, you stretch a little bit more because connective tissue releases more on the breath out. You hold it and then normal breathing in and out through your nose and then stretch a little bit more as the breath out. So it's a very beautiful lengthening of that muscle. And then you gradually, gently come back up. Be really gentle with your movements with your neck because all the fine little structures have got to adjust to come back to neutral. And then if we do the right side, you pull your right shoulder blade back and then you tilt your left ear to your left shoulder, turn your head slightly to look to your left armpit. And then you'll get that stretch on the side and towards the back a little bit of the muscle fibers. And then you're holding that. And you just maybe let it go a little bit more in that position as you breathe out. And you'd probably want to hold that for, 10, 15 seconds. Do 2 or 3 on each side, at least a couple of times a day, and that will make a big difference. And it's not a big deal in your day then. It's actually just a relief for your body. Yeah? So then, thanks, Anne. Then you have these breaks within your work structure that support your body to come back so that you're decompressed, yeah? And you're more balanced with your connective tissue around the body parts that are working a lot with your work. You're going to enjoy your work more, you'll feel more vital, and you'll be more, you'll just be more at ease with your clients as well. Now, I've talked a lot, and we've demonstrated quite a bit. Does anybody have any questions?
Oh, yeah, Arthur?
Yeah.
That was very interesting, and I think a lot of what
Do you want to go up to the microphone, please? Thanks.
the association of connective tissue stretching and yoga, in my mind, I think that they're connected because the movements that you describe are very much embedded in a lot of physical postures of yoga as well. Is that what you think? Or?
Yeah, there's very much a parallel for some of the. It depends on what philosophy of yoga you're talking about. I mean,
Leaving aside keeping it to the asana
Oh yeah, the more relaxed, the more gentle.
Hatha yoga being flow.
Yes, yes. That philosophy, yes, is very much in keeping with what I've found is the most supportive and nourishing for the connective tissue, so that you move smoothly. You can still move at a medium pace, but the quality of the movement is smooth. Yep. So you go into your what are they called again? I've forgotten. It's been a long time since I've done yoga. Asana? You go into your asanas or your yoga posture, and I do still some of them. The cat stretch and all of that is very, very useful for the spine. But you move into them smoothly. It's just respect, really. It's respect for the body. And as you move more into the tight zones, you're doing it with the properties of the breathing. So you definitely don't hold your breath, and you definitely don't hold your lower tummy. There are so many times we're holding our lower tummy out of anxiousness or out of insecurity or whatever, or we feel like we have to hold it. But if you're holding that all the time, it's a skeletal muscle. It actually gets tired, and then it gets weaker. And then weak muscles get tense, and then they get sore eventually. But yes, I see what you mean. There is a parallel. It's the awareness of the breath, because I always, with my clients, say, just like I did there with Anne, as you breathe out, let the tissue soften more and lengthen more, and it will. So thank you for that.
Excellent. Thank you so much, Kate. That was excellent and highly useful.
Thank you, everyone.
If there's any other questions, we'll keep them to the end. Kate will be here at the end. All right, we do have to move on. John is going to introduce the next session. Thanks. Thank you, John.
Welcome to the mentoring part of this professional development stream. I'm John McCoombes. I'm a fellow from Queensland, and I'm on the CPD and the Health and Wellbeing Committee. We were going to do a little bit of live polling, but I think in the interest of time, we'll cut that out and just go straight to our very experienced panel here of mentors that I'd like to introduce. So the first is Karina Kim, who's a GP based in New South Wales and came to the Royal Australian College of GP mentoring program as an experienced mentor in 2020, and continued her mentoring leadership role until the end of 2021. With a clinical interest in mental health, particularly work burnout, Karina was a very popular choice as a mentor for both years running. During her time as a mentor with the program, she mentored 3 new fellows. Dr. Nicole Liesis, who's an emergency physician passionate about harnessing individual strengths and diversity through mentoring. She leads the Australasian College of Emergency Medicine to embed high-quality mentoring as part of important professional development strategy that builds on a culture of support and encouragement. Nicole is also a qualified strengths coach and founder of Coaching for Medical Professionals, which believes that fixing weaknesses may prevent failure, but working to strength lead to real success. And Julian Boulnois is in his 67th year, and he's hailed from Bristol via Queensland for 40 years. He is a fellow of the Royal Australian and New Zealand College of Psychiatrists and has spent time in general practice and family medicine. He enjoys mentoring greatly and is happy that mentorship and menteeship is beginning to become an important part of collegiate life. So we wanted to just look at some myths that surround mentoring, and we're going to concentrate on three. I'd like each of our panellists to make a response to these myths that we're talking about. So the first one is that mentoring is a natural ability. Put another way, I already mentor people because I have friendly chats with them. So, Karina, would you like to start by giving us your opinion about that statement?
I think a lot of us do have a baseline kind of mentor capacity, but it is something that requires a level of training and something that we can actually work towards. So you can have people that think, oh, look, I don't think I'd be a very good mentor, like, it's not really in my wheelhouse. But you can actually get training and learn and develop. It's a skill set like anything. You go to medical school, fresh out of high school maybe, or you've done a completely different degree. You don't know what you're doing, but you learn and you train, and the more you do it, the better you get at it. Mentoring is exactly the same. But I do think to be an effective mentor, you do need to have training, but also to have continual training and continual input, just like we do with our medical continuing professional development skills.
Yeah, thank you. Thanks. Julian, what's your opinion on that?
Mentorship is a very strange kind of conversation for most doctors to actually have. My own college was somewhat backward in coming forward in thinking that we, after all, we're psychiatrists and we understand these things, which we don't, but we say we do, should need a scheme such as mentorship. But then we began to lose skillful young registrars at an appalling rate. And we began, or my colleagues in Melbourne began to realize that this was a great loss of potential and manpower and womanpower. So they put into practice a scheme which is called mentorship. You can call it anything you want. I'm not sure whether words like mentorship and menteeship and being a mentor slip off the tongue that easily. But basically, we're talking about something very simple. We're talking about a simple communication between people who've traveled a certain way down their clinical journey and people who are just stepping out on that clinical journey. And we need to be able to translate that into a language that people understand. It's not a language based on pathology. It's not a language on a medical model, which might make us feel a little uncomfortable. It's a language based on the ability to be oneself and to share oneself with somebody else in a situation of total privacy. And by doing that, I might say in a very practical sense, by investing this thing called mentorship, our registrars are now sticking around a great deal longer, which is the important endpoint of any college which has a collegiate background, actually doing something for those of us who are somewhat long in the tooth. I guess I'm longer in the tooth than most of the people here, to be perfectly honest, giving back something that was given to us years ago when we had bosses and we didn't have supervisors and we didn't have complicated exam systems. We just had the old man who we'd wander up and talk to. Well, that doesn't happen anymore, sadly. So we have to have a different scheme of talking, which is just as important as anything else because it keeps people there.
Very good.
Yeah, fantastic. Nicole?
Could we get the slides set up, please? Would that be all right?
Yes.
In the slides, what we've done is just put a very brief overview of the various colleges because we're very different colleges in size and dynamics. That will come up at some stage. While we're waiting, in answer to your question, one of the important things for me about this question is I have a confession to make. I thought I was a pretty great mentor. I took a lot of young doctors aside, particularly women, to check in on them and work out how they were going and give them some advice about job interviews and stuff. But they were really just friendly chats. And now, having done coaching and mentoring is a series of progressive conversations. So it's not just a single chat here and a single chat here. They're chats. But it really is working from one point and as Julian mentioned, journeying together. The journey will look very different for different people. And there is most certainly a skill set required to go on that journey together. But it's really important to think about where you begin and what's going to happen next and some actions and what are you going to try and what didn't work and what's happened and something bad has happened, I'm here for you. So for it to just be a friendly chat, we do that all of the time, but it needs to be a little bit more than that to provide that support and that longevity over the journey of someone's career. And I'm just going to get through to this one. And a good doctor does not make a good mentor. I kind of thought it did as well. But a good doctor is good at diagnosing and prescribing. A good mentor is good at exploring and asking questions and having no idea what the answer will be, but helping the mentee to actually discover that themselves. And it's about empowering that mentee to understand what might be going on and for them to solve the problem, not to be fixed by someone else.
What formal courses did any of you do to learn that skill?
So with the College of GPs, they run an online session with, I probably can say his name now, Oliver Schultz, who basically gave us an initial 2-hour session, lots of slides, lots of education, lots about how to approach things, how do you set boundaries within that mentor relationship, a lot of education around that, as well as a guidebook. And then moving forward, probably an hour or 2 session every month as an ongoing professional development on, next steps. These are things that you can use to approach your mentee. How do you get the information or how do you help them structure, where am I at in my career, in my personal life? How do I find meaning in my job? How do I find meaning in trying to bring these things together? So what approaches can you use? Yeah.
Initially, we didn't really have a training scheme, to be perfectly honest.
And how did that go?
We thought we knew it anyway, so we sat round large tables and ate minties, and lots of minties, and we invited people we thought were experts to come and give us lectures, but we got a free afternoon out of work and a free dinner, which probably is the way everyone begins, in a strange kind of way. The important thing is that's not the way to do it at all. The way to do it is to put out for expressions of interest in a traditional kind of way. The college has, my college has a sort of recruitment drive at the beginning of every year, and people are encouraged to go to the website to download a booklet that we've produced, which is available for people to work out whether it's something they really would like to do. They then express an interest in what they would like to do. And pre the COVID crisis, unfortunately no longer there, but pre the COVID crisis, we were able to get a dinner in Melbourne, but with a great deal of expertise attached to that, and which was ongoing, and even during As years goes by, we're asked to provide feedback twice or three times about the nature of the partnership and how it's actually going. But the bottom line is it's very difficult to put chapter and verse and this amorphous set of ideas into something which is nice and neat and concrete. It isn't. A mentor can be anybody. I trained as a psychoanalyst. That does not make me in any way a better mentor than anybody else. It's experience and the ability to share oneself to another person in an atmosphere of total privacy. It's that business of privacy that's so terribly important in this interrelationship. And then there is a magic in mindfulness, there's a magic in connective tissue, there is a magic in mentoring as well. And the magic is what we learn, that combination of experience and training from people who've been doing it much longer than we have, and there should be more of it. And I personally feel that everybody in every college should either be a mentor or a mentee, and then they can swap the next year, and they can turn around and be the other. And I think that's important too. There's no age limit. I'm 75, I have to admit it, and basically that doesn't make me a better mentor than somebody of 35. No way. It's, are you able to be yourself with another person with the aim that maybe the sharing can actually support both of you in your journey, which is a long and difficult one and not likely to get easier, I suspect, to be honest.
The perspectives I bring are actually accumulation of several years of work we've done at the Australasian College for Emergency Medicine embedding mentoring. So every training site in our college has to have a mentoring program. They look different at different sites, and one of the requirements of those is that there is some form of mentor training. I will challenge you a little. I do think there is some skills that can be taught, not the art of it, but the skill of it can be shared. And we've actually I've developed some online learning modules. In fact, there's 15 of them that look at just different techniques and different areas to consider: leadership, wellness, burnout, asking questions, how to listen, to just give people some props to start with, so then they can start doing the magic tricks on their own. But I do think that it's a really important part. We don't make training compulsory, but when we assess each program, we do ask, what training have your mentors had? It's a well-documented feature of programs that fail, is that the mentors and the mentees, who also need a bit of orientation and training, haven't had training. So
it's fair to say that there's, like anything, there's skills to learn, but putting it in practice is very important, and you grow as you do more of it over time. Yeah. So next one we might address is mentoring is just part of clinical supervision, where a lot of us are clinical supervisors in hospitals. Mentoring is just part of that. Performance enhancement, performance review and clinical supervision. It's just the same. What do people think about that? Who'd like to go first?
Can I jump in on that one? Yep. The biggest challenge we've had is overcoming people's pre-existing notions of mentoring, that it's about the problem child, and it's the one that needs some help, and that's why they're getting a mentor. And so we've had to reframe that. Mentoring is not about supervision. As soon as supervision and assessment comes into it, then you're sharing that conversation outside of that partnership, and that trust is breached. So one of the fundamental components of mentoring is that there is confidentiality and trust held in that relationship. If there's actually an issue where perhaps the mentee is in danger, then you may need to breach that, and you would have a conversation to let them know under duty of care that was going to happen. But it's been very difficult even in our setting for people to separate the notion of supervision and performance management away from mentoring, to the point where our mentoring mentors are not allowed to be their supervisors. So we separate it articulately. Yep, that's enough from me.
But there is an overlap.
Or
is it not an overlap?
Is that right? Yeah. What we do know is that teaching supervisors and people who provide feedback coaching skills and how to have constructive, thoughtful conversations that involve the person that you're having it with, those skills of mentoring and those skills of coaching are very helpful in providing clinical supervision and performance management. But as soon as you go outside of that chat, as Julian mentioned, you've breached the trust. So no, they have to be separated in my mind. And if someone has to do both jobs, they literally, we sort of say, look, you have to put your mentor hat on, and now I'm taking that off, and then I'm putting on my supervisor hat, and you didn't perform well enough. Even though I know your family's kind of falling apart and that sort of stuff, you haven't met the grade. So that's the separation where it becomes quite difficult. And throw to you guys.
Yeah, I would agree. I personally wouldn't think it was appropriate for a mentor to also be the clinical supervisor of the same person. I don't think it's easy. You can't.
Because sometimes as a supervisor, you become a mentor when you're not supervising them down the track.
Yes.
So if someone does a 3-month term with me, I've taught them operations, but then 6 months down the track, I get a call saying I'm not coping with this term.
Yeah.
So that's the division then.
Yeah, but now you've been taken out of that clinical supervision role. So I actually think if you're also a clinical supervisor and their mentor at the same time, there's a conflict of interest there. You can't really separate it. But once you're no longer their clinical supervisor, obviously you were a great clinical supervisor because they're actually coming to you as a mentor. So they have that trust with you, but then you're no longer in that setting where you have to give them feedback on their performance. You can then help them manage and navigate whatever issue they're having separate to how they're actually performing clinically. And I think that's really important. And as Julian mentioned, it is all about privacy and trust, because you're now not going back and writing a report on how they've performed today. You're just giving them honest guidance of how to deal with that difficult situation.
Yeah.
Another scenario is someone that's done something, in my setting, they've done a bad resus, and then they'll be in, the consultants will go, oh, who's their mentor? You need to talk to them about that resus. No, the person who is in the resus with them needs to talk to them about their performance in the resus. The mentor might go, oh, how are things? Any recent events? I heard that maybe something didn't go so well the other day. What was going on for you? How did you react? Did you realise you weren't performing well? What was going on? How could you deal with that differently? So it's about improving performance, but not about the performance critique. Does that help to separate it a bit?
Yeah, I think just conventionally we've always thought of them alike, but they're actually not.
That's the challenge.
Yes.
I think we busted that myth, did we? Julian, did you have anything else to add to that?
No, I think it's been said. I think it would be a psychological impossibility for someone to hold down the roles of supervisor and mentor. And people have tried to do that. And the people to be the most wary of are the people who think they can do that. Because quite obviously they cannot and have little understanding of either skills. And maybe they should become mentees, is all one can say in such a situation. I don't think it's a possibility in terms.
All right, so let's move on to the next one, which is that the myth is that it's good for the mentee rather than the mentor.
Again.
You do so well.
So obviously, I think mentees go into the program for a reason, but mentors also go into the program for a reason. I can only speak for myself why I did it. In our college, it's completely voluntary. I don't get paid. I don't get anything out of it. So I take time out of my evening away from my kids. So that's actually a benefit. I get time away from my kids in a room, and I can close the door and say, Mummy's in an important meeting. But it's going to sound really teasy, but it gives me the warm and fuzzies, right? Because, as you mentioned, and I'm pretty vocal about to whoever wants to talk to me about it, I went through a period of burnout, took 6 months off clinical practice, and unfortunately, with the way that general practice is currently going, it's a common theme. And I think having gone through that and come out the other end and gone back to clinical practice in a much healthier way, I now have that capacity to share that experience with other people. And while their exact situation is going to be different to mine, I then have that experience of, well, look, how do we problem solve your situation? Let's get your priorities right. What is the most important thing in your life? Where do you see yourself in 5 years? What makes you happy? What fills your cup? And that fills my cup. Like I said, it gives me the warm and fuzzies that I can actually help someone, guide them through that process.
So we give a lot to patients, but this is giving to a colleague.
Yeah.
This is giving to
And ourselves.
And you get something back from it, because it's like you watch them grow. It's not quite like a kid, but
I
yeah,
have
you
to
watch
say,
them grow.
I miss my mentors, who sadly now, by virtue of have gone to a better place, hopefully by now, at a great asylum in the sky. But sorry, I didn't say that. But they were wonderful people, and I so value their input into my life, and I feel, not in any philanthropic sense, that it's my duty to give some of that time back. And I agree, I'm primarily a private practitioner. This has nothing to do with money. This is all done in my own time, in my own way. But a point that hasn't been raised is, one of the primary differences is that this is a conversation, yes, between mentor and mentee, but it's a mentee-led conversation. It is the mentee who phones up and makes appointments. It's a mentee who signs on. And even in the beginning, it is the mentee who decides and chooses the type of mentor that they might actually like to actually be involved with. So in that sense, there is an imbalance to the relationship, which I think is a very important imbalance. Imbalance in the sense that the power is given back to the mentee and away from the mentor, to avoid any sense that somebody is doing you good, which is something that should be avoided at all costs, I think.
And it's getting over that stigma for the mentee to reach out, which we've found in our specialty. Yeah.
I'm going to tackle that a little bit differently. This is something that's taken us many years to get to, but what I think when we think about overall well-being, as doctors, we focus a lot on the training circle around gathering knowledge and clinical expertise. And for many, many people, that circle is huge. Mentoring, so that's about what we know. Mentoring is really about how we do the job. So how we make clinical decisions, how we interact with other people, and how we do things. Wellness is about, can we do the job? Am I physically fit? Am I emotionally fit? Am I culturally fit and able to be my true self in my workplace? Am I well in myself? And I think for many doctors, that wellness circle's tiny. For some of us, the mentoring and coaching will be there, but then the training thing's this massive thing. We want to get a balance back between all three, and it's right in that little central triangle that you really have the doctor well-being, the doctor that's at their most well, who can perform at their best and who can engage in their work and who can be retained at work and do the best by patient care. So mentoring actually benefits patients. If we're centred and happy and well with this great balance in our lives and not just focusing on what we know, then our organisations and our patients really are the great beneficiaries of all of this.
I guess just a little bit following on from that, getting that the combination mentor-mentee right and a good match is an important part of this. So what do you do to get that right? You know, how do you get that right?
In simple, practical terms, you meet. I mean, in the training that we set up, people made their choices and then had the infamous dinner without the with mentees, not mentees, and we'd actually meet each other over dinner table and we talk. And again, the control, the power is in the hands of the mentee. The mentee has every right at that point to say, I can't possibly talk to that person, which comes as a bit of a shock sometimes. In my case, it's because I speak in a peculiar and strange way. I say other people have accents. They say I have an accent. It depends on which way you look at it. But that's okay. That's fine. If that's a real bother, if that's an impediment in the eyes of the mentee, then so be it. So be it. But again, I'm sorry, it's mentee-led all the way, and I think we've learnt the hard way, I believe, that is very important.
Across our sites, we don't stipulate a matching process, but we stipulate that there must be a matching process. The commonest process that's adopted by sites is that there is like a profile for the mentees and a profile for the mentors, and the mentees can select their top 3 of the mentors that are available, and then you try and match. So that's most commonly done. I've actually matched people just on knowing who's who with profiles, so that gives some information. They've tried to match common interests. Matching for compatibility is the key, not for convenience. So not just putting up the 2 lists and going, yeah, that's usually a setup for failure. Yeah, but it's some sort of matching process. And I will put in, we have over 1,000 trainees that are currently participating in mentoring, but I would suspect that maybe a quarter to a third of those will progress onto relationships that really kick off. That seems to be the rough figure that we've got, because people either choose to make time or not, and the mentees will not engage. And we don't see that as a failure, but the option's there.
The contract isn't just for the year. I have 4 mentees who come from many years ago, who I still keep in contact with. I'm not sure who's mentoring and who's mentee at this particular point after that length of time, but it is an ongoing thing. And some people drop out halfway through to leave the country. That happens too as well. So there's a room for flexibility in this as well, isn't there?
Can I ask, is there any questions? We really haven't had a lot of time to explore it in great detail, but sorry, Anne, yeah.
Hi, I've just got one. Our Mentor Loop program is quite new, and I've been matched with a few people, and I've had wonderful initial conversations with them, just receiving them and getting to know each other. And I say that's so helpful, and be in touch. And, and the Mentor Loop thing is good because it sends you an email reminder saying, how's your relationship with that person going? And you go, oh God, I forgot about them. And I'll write to them or give them a call. And I find the follow-up is the issue, that they get busy or they go away, or maybe it wasn't that useful and they're just being polite, I don't know. But just how, if it's mentee initiated, how do you support the mentee to keep initiating it so that it actually becomes a relationship, not a one-off thing? Or is there a need for them to be more, look, that was great, but I don't feel like that's going to be ongoing useful, so that you're not sitting there going, I don't know what's going on.
I'll tackle that one, because, very much one of our rules is it must be a mentee-led relationship. However, I do think that the differential between a consultant and a trainee still is there. And so there is a bit of a hierarchy thing. So I've suggested to a lot of people, look, it needs to be mentee-led, and maybe they just need a little bit of help with that. So I would encourage that. I would reach out and say, oh, how are you going? Shall we set up a meeting? You let me know when you're available in the next few weeks. So it's a bit to and fro. And it might be a little bit around structuring when you meet with them. Okay, when are we going to meet again next? Let's set a time frame and setting up a meeting. So you're getting those skills of mentoring for it to be progressive at the beginning. And voicing that there's a bit more of a structure. And there's always a struggle when trainees are at the study part, coming up to exams. Yeah, everyone knows a mentor would be great, but I could do some more study, or I could just see my mentor. And so we see that most prioritise the study and just getting through the damn exam. Although, that tends to be what happens as well. And I know that your training program sounds incredibly intense as well.
No, it's dominated by exams every year. Yeah.
But what would be helpful is actually that if time is articulated, that you get set time for mentoring. Yeah. We provide CPD points for mentors and mentees.
Yeah, we do. Yeah, we do. Yeah.
You do that as well?
Yeah, we're going to. Yeah.
I mean, it might be my prejudice, but I would imagine the online platform to connect is just singularly unsuited to this sort of relationship. I think it's got to be an in-person most of the time. What do you think about that? I don't think it necessarily needs to
be so the 3 mentors I've had, they're all over New South Wales, so it's only ever been via Zoom.
Okay.
And I initially thought, oh no, I was going to have coffee every week with someone, we're going to catch up. No, it was it ended up being a once a month session via Zoom. But I think in terms of the disengaging of your mentee, what can help is if you actually have, so as part of that initial, yes, let's get to know you, but actually be clear, look, what is it that you want to get out of this? Because yes, it's actually a bit more about you than it is about me. And so what are you hoping to achieve? Or why did you pick me as your mentor? What do you want to pick from my brain? And let's have a plan of action, you know? And so then towards the end of, say, that session, you might say, okay, well, look, is there anything that you want to action between now and next time we catch up? I know that sounds a little bit like homework, but I think it is actually very helpful because then they actually have it in their head, okay, well, I'm actually going to have to think about, well, look, what is my career path? Or what is it that I'm struggling with? Or what is it that I'm doing really well with, but maybe I'm not getting recognised, or whatever it might be. And then, okay, we're going to catch up again. I actually found I just set a time. Okay, well, let's catch up in, what do you think, 3 weeks? Is that going to be good for you? Oh, no, I'm going out for dinner. Okay, well, yeah, so you've actually got it.
Part of that conversation.
Yeah, yes, it's actually in the calendar then and there. And then I just send out a reminder the night before. And that seemed to work for me. But, you know,
Super practical.
yeah.
Can I ask one more? Is that okay? Just with this supervisor mentor thing, because some of us are supervisors, and in the process of being a supervisor, it becomes apparent there's a problem. You know, people don't usually just, there's no crap registrars. No one's a crap registrar. So if something's happening with their performance, something's going on. So when you flag that, you know, particularly because I'm in the country, there is no one else for them to go to, really. Do you have any practical suggestions for how you support them if you can't be that person for them yourself?
Well, that's where it would help if you had a mentor program where you can have remote access.
Yeah.
So they can have a mentor that's in the city or that's in the Northern Territory to kind of have those other discussions. But then I guess the other thing is, big advocate, doctors should have GPs.
Yep.
And so the role of the mentor is not to be their GP either, or their psychologist or psychiatrist.
Or their mum.
Or their mum. Yeah, they need to have those themselves. The mentor is there to provide that framework in a collegiate or more career kind of sense.
In some of our we have a number of smaller sites, and that does actually happen. So we do have mentors who are supervisors. And so I think it would just be about articulating one in your own head. Okay, I'd like to have a mentoring conversation with you now. And then, okay, we're going to have a supervisory conversation. And I think even articulating to the mentee, I'm really trying to separate these two, and maybe I won't get it right. And please help, you know, but let's sort of see how we go. And just being aware of that confidentiality and trust. And I think being open and sharing the difficulty you're having with that is really powerful as well for the mentee. Often sharing, you know, when I've been, you know, having trouble, or people always think the consultant looks so cool, calm and collected, and you're like, oh, no way, man, you should have heard what was going on in my head. We're very good in medicine about being, you know, looking awesome, but not being awesome inside. And opening up those conversations is really incredible when people feel safe enough to actually voice that they don't look as cool as everyone else, and for you to go, yeah, it's actually, we're not that cool. You're just normal, and let's sort of talk about some strategies around that.
Absolutely.
Look, we might have to leave it there, unfortunately. That's been fantastic. Andrew, thank you very much, Andrew, and Kate, thank you for your contribution, and Julian, Katrina, and Nicole, fantastic work.
Thanks.
And we really do appreciate you coming along and starting these conversations with us about these important issues. Yeah.
Yep, great.
Thank you
very much. Thank you.
Thank you for coming along to the session.